I'm honored and privileged to introduce Dr. Singh, who's one of our core faculty, hepatobiliary surgeon and associate professor of surgery. Dr. Singh has trained at Jefferson under the tutelage and mentorship of Dr. Charlie O, who not only did a general surgery residency, but did a GI hepatobiliary fellowship with him for several years. And since then, he joined us on faculty and has built an outstanding hepatobiliary and advanced GI surgery practice, has been a resource for our general surgeons and trauma and MIS, helping them with the complex GI surgery, whether it's intraoperatively and or consults. He's published in the field in several important papers and presented nationally as well. At the local level, Dr. Singh serves as a core faculty. He oversees Journal Club and the PROS program, which he relaunched with Dr. Patel, that focuses on professionalism and leadership for our residents. And I appreciate your help and support with that. He also serves as a co-chair of the Surgical Quality and Safety Committee of the hospital, along with Dr. Punja, another Jefferson graduate as well, and has done a lot of good work in the field. Today, Dr. Singh is going to talk to us about surgical management of giant duodenal / peptic ulcer perforation. Thank you so much, Dr. Singh.
So it's not going to be our conventional grand round. It's mostly going to be how can we fix these patients surgically. There are not a lot of randomized prospective trials in these cases because the chances of giant perforations are only 1 to 2%. Meaning technically, if you're fixing 100 perforations in your 10-year career, you are going to see 1 or 2 or 3 of those, and how are you going to do this randomized trial? So I'm going to discuss all the various surgical procedure which we can do and how to fix it. I'm going to stop after each procedure and make you have a chance to ask questions, clarify your thoughts, how to do these procedures, risk and complications of each. Okay, so let's start with the disclosures are none. So obviously anatomy in Latin, the duodenum means like 12 fingers, not like 12 fingers in length is together. And technically the length of a duodenum is 25 to 30 centimeter. It's C-shaped structure lying between L1 to L3 vertebrae and is continuation of the pylorus proximally and jejunum distally. And segment of the duodenum, we'll show you the pictures too. Duodenal bulb is the connects to the undersurface of the liver as via hepatoduodenal ligament, which contains the portal vein, hepatic artery, and common bile duct. And I think all of you know the thing, but make sure you know the relationship of these structures to each other too. Second and descending segment is just above the IVC and the right kidney, with the head of the pancreas lying in the C-shaped concavity. Third segment runs from right to left in front of the aorta, IVC with superior vessels in front of it. And fourth segment continuing as the jejunal. So obviously, a lot of complex thing over there, but just want to say from here, this is pylorus to the bulb is a D1, down is D2, horizontal again is D3, and continuous D4. You can see the vessels, SMV and artery on the coming in front of the D3, and obviously kidney and RVC just behind, and the pancreas over there. So just normal anatomy for students and the residents too. So blood supply, why the blood supply is important in this presentation, because some of these perforations do come with a lot of bleeding. So you have to know what are the blood supply for these regions, because perforation can happen in D1, D2, and even the D3. And you have to know the bleeding, where the bleeding, like blood vessel supply, where the bleeding is coming from. So most commonly the branches of the gastroduodenal artery. Gastroduodenal again with the branches from the SMA make a pancreaticoduodenal arteries, which is definitely you can say is the superior anterior posterior pancreaticoduodenal arteries, which are branches of the GDA. Then SMA, you can have an inferior anterior and posterior pancreaticoduodenal arteries, which combine together like an anterior and posterior form the final pancreaticoduodenal arteries. But if you have a giant perforation in D1 and D2 area, the bleeding, if it's happening, is coming from the branches of the GDA or GDA itself. So just a little bit of introduction. So perforated peptic ulcer is a common life-threatening surgical emergency with mortality ranging anywhere from 10 to 40%. I know some people can say it's too much high of the mortality, but we will discuss more on that. Even I do a lot of research on that. It's still more than 30% in that today's world. where PPI are very common, like proton pump inhibitors, PPI. So duodenum is the commonest site with 60%, followed by the antrum, 20%, followed by the lesser curvature, 20%, and most of the perforations are less than 1 centimeter. Surgeons rarely encounter an ulcer with a diameter of more than 2 centimeters, which is often considered a giant. Again, this 2 centimeter is the most common word used in the literature. Some say 2, some say 3, but we keep a 2 centimeter and more as a giant perforations. It comprises only 1 to 2% of the all duodenal ulcers. Its definition and ideal surgical management are not well established. That's the biggest thing. There are no protocols. How are you going to manage these giant perforations? There are no like, okay, you have perforation in the D1, just do this surgery. You get perforation in D3, just do this one. Or in the stomach, just do that one. There are no set protocols. So it's really a hodgepodge of all the different surgeries and your comfort level, and depending on the patient situation and depending on the tissue you are going to find during the perforation, that will define what surgery is best for that patient. So we will discuss more about that too. So again, no standard definition, whether it's small, large, or giant, even though size correlates well with the operative outcome. So no definition, but size of the perforation is directly proportional to the mortality of the patients. In general, the mortality rate was only 6% when the size is less than 5 millimeter, but rose to 24% when they are around 1 centimeter and is much higher in a giant perforation, around 17 to 40%. Such high mortality rate is expected as the giant duodenal ulcer typically associated with major duodenal tissue loss, friable edges, sounding inflammation, and infection. So all the triad of inflammation, infection, and friable tissue, and the stitches are not going to hold together. They're not going to heal well properly. So what's going to happen? Leak again. So we have to decide what we can do best in those circumstances. So no clear definition. Any ulcer with a diameter of more than 2 centimeters, and some literature say 3 centimeters should be considered a giant one. So before we start all the surgical procedures, obviously, before you go into the surgery, you need to know what are the outcomes you are going to face. And outcomes you are going to face will depend on all these risk factors, which are going to contribute directly to your morbidity and mortality. So loss of tissue, like how big the perforated area is. Is it inflamed or friable tissue? Is it infected tissue? Whether the defect can be primary closed or not. Most crucial factor is obviously hemodynamic stability of the patient. And size of the perforation, again, low albumin level less than 2.5 and a hemoglobin less than 10 is again going to contribute too much into the risk for increasing the morbidity and mortality of the patient. So management can be divided into two parts. One is the non-resection, one is the resection. Obviously, we can all say why we have to resect the perforation and we can just stitch it. So we will come into those things too. Non-resection part is like a primary repair of the perforation with the omentopexy. I think that's the most common procedure which we use on day-to-day practice. Second is the omental plugging. I think no one is using that right now, but it's also an important one. Gram patch and the triple tube ostomy. No one is doing the triple tube ostomies too because it's a historical importance. We will discuss about those things too. The section is enterectomy with reconstruction or subprotogastrectomy with reconstruction, pyloric exclusion with gastrojejunostomy, jejunal serosal patching, and tube-based repair is a tube duodenostomy. We'll talk about all in detail. And if you have any question anyway, just stop me. We'll go slowly on those things. So just look into this slide properly. There is too much or there may be nothing. But need to remember all these things. So just a primary closure, just stitching the ulcer together, you can do that. When the edges of the ulcers are good, tissue is good, healthy, you can just primary close that. Primary closure with omentopexy, you close the tissue primarily and then put a omentum on top of it and then make sure the omentum gets stuck to the sutured area. So this is the most common procedure which we do. Now the other one is the omental plugging. You take a omentum and put through the hole of the ulcer, and then to stitch the omentum to the edges of the ulcer. Just a simple omental plugging. Now these two are in between the and combination of both. Means you are repairing it primarily plus also doing the omental plugging. So this procedure, if you say, is called a Phelan-Jones procedure, was developed in 1927, and Graham patch in 24 or in 1934, and we're still using that one. It's like almost 100 years now. But what are the difference between the Phelan-Jones repair and the Graham patch? If you look over here, we put stitches through the ulcer area and then put a omentum on top of it and then close that. It gives a combination of primary repair plus omental plugging. But what's the difference between these two repairs? The omentum which is used over here is a pedicle flap, means you don't cut the omentum, you use the pedicle flap. But in the Graham patch, you use the omentum, cut it over, and put it directly on top of that. So we keep on using the Graham patch, but we may be using the Phelan-Jones if we're not cutting the omentum. So remember those things in your words, like when you think, oh, you did a Graham patch repair, I'm going to say you did this thing, but in that say you may have done that one, you never cut the omentum. So any question on this slide? Okay. Now, again, there is no prospective randomized controlled trials. Which one is better? Primary repair with the omentopexy or omental plugging? I just found, obviously, there are not a lot of number of cases which we can find day to day. There are only very small numbers which you can divide into two groups and do some prospective trial on that. So I found this paper, obviously very, very small number, maybe 30 patients, which they have divided into two groups, and all the perforations are more than 2 centimeters. In that, they have found that omental plugging has a better outcome as the mortality rate as compared to the omentopexy. And we can talk about that too, but in the first 24 hours, death can be just because of the multiple comorbidities, peritonitis, and all these things. But if a patient is surviving for more than 24 hours, can be contributed to the technique how we have fixed those cases. In the omental plugging, what they have done in that is they put the NG tube to the stomach, get the tip of the NG tube out through the perforation, tie the omentum to the tip of the NG tube and pull it back, and then stitch the omentum to the edges of the perforation. But on the omentopexy, again, you just have to close it primarily and put a patch of the omentum on top of that. So again, they have done all the different morbidities in this kind of patients, but again, they all are not significant. Only significant factor is a fistula, means leak again, and leak is again more in omentopexy than omental plugging. So indirectly, they are saying that omental plugging may be a better option for the giant perforation patients. Why? Again, the tissues are friable. You try to close them with the stitching, they may break through, they may never going to repair properly. It's inflamed, infected, and friable. So best is to do mental plugging. Mental plugging will cause a tension-free repair. And secondly, if you're going to tie the omentum with the tip of the NG tube, we're going to keep it in the position. So both of them are going to help you with that. Okay. So the tube-based repairs are triple tubeostomy. Normally, no one is using that, but again, it's still a good option if you keep in the back of your mind. This is mostly done for the morbid patients who are not going to withstand any kind of resection or reconstruction. You can repair the perforation primarily, and then can have a G tube for decompression, and then you have a retrograde duodenostomy and a feeding jejunostomy to help them with the repair. But I have never seen that. It's in the literature. We can always discuss and talk about that. How can we do it? So obviously with feeding jejunostomy, we know that we can remove those tubes and they will slowly heal properly too. Retrograde jejunostomy is most commonly used by the trauma surgeons in a complicated and complex duodenal perforations too. And this can another viable option to repair in a patient which is very comorbid, where the albumin level is very low, where they're not going to tolerate any kind of resection. Now we can talk about the resection and the reconstruction. For the large, so enterectomy or enteroduodenectomy with the reconstruction is most commonly being done for the large first part of duodenum or duodenal, pyloric and pre-pyloric perforations. Obviously, it is mostly in the first part of the duodenum, and in the antral area, you can resect that and then have to make sure you have to do a drainage procedure for the stomach in the form of gastrojejunectomy. So this is mostly done in a patients with a large perforation in this area, plus you can't close them primarily, or if you close them primarily, there are going to be high chances of stricture or obstruction after the repair. So better to do the enterectomy and the drainage procedure in the form of gastrojejunectomy. Any question on that one? Everyone knows about that. Most of the residents will know about that thing. Now we're going to talk about this tube duodenoscopy. Okay. A very life-saving procedure, but not very well known. But a lot of things, like when we were discussing about Dr. McNamara patient and we were talking about the lateral duodenoscopy and pyloric exclusion, and Dr. De Rosa told me I need to present that. So we took her recommendation. We're presenting this PowerPoint and then all the grand around here too. So you can do the tube duodenoscopy in two ways. You can go from the stump side, or you can go from the lateral side. So through the lateral wall of the duodenum or through the duodenal stump. We will talk about those things too. But the best outcome in this study, they have found that they can decrease the morbidity to 12.9% and mortality down to 6.4% in a very, very complex situation where the mortality is almost 30 to 40%. So it's a well-known procedure, but not done properly or not being utilized properly. So how you can do that in the stump area? So let me go back over here. So if you are resecting over here, you can have a duodenal stump. You can just fire the staple across that, but depending on the viability of the tissue, you can put a tube through that. Okay, I'm going backwards. You can put a tube through that, first stitch around that, and put a lot of Omental around that as a tube duodenoscopy through the stump of the duodenum. Or you can do the same thing from the side wall of the duodenum where the perforation is happening. Okay. So tube duodenoscopy is normally not done alone. It may be combined in different kind of procedures depending on the location of the perforation, depending on the size of the perforation, depending on the type of surgery they have been doing. So if we look here, most of the tube duodenoscopy are done with a bleeding duodenal ulcer in 6 cases, but done with an enterectomy and vagotomy. And if you look right over here, they have done the T-tube also to drain the bile out of the bile ducts directly. So T-tube plus lateral duodenoscopy plus vagotomy and enterectomy too. It's not only one procedure, it's complex procedure, hodgepodge of a lot of things to make sure the patient is healing properly. And obviously obstructive duodenum too, maybe depending on the stenosing ulcer or tumor. But again, a lot of cases have been done for perforative bleeding ulcers in trauma cases too. They are being done in combination of enterectomy, hepaticojejunostomies, enterectomy alone, or reconstructing gastrojejunectomy with or without the T2 placement. So if you're doing the lateral duodenostomy alone, it may not be helpful because a lot of studies are done. The best thing which can let the perforation heal are two things. One is the drainage, and second is the decrease the intraluminal pressure. So lateral duodenostomies are good for the drainage procedure, but they may not be contributing enough to decrease the pressure in the lumen. So that's why they have to make any type of reconstruction to let the drainage happening properly on those cases. So I'm going to present that, but I'm going to show you how the tube duodenostomy is being used with the pyloric exclusion also. Any question on the duodenostomy? Yeah, go ahead.
I think I know the answer that you're going to say, but maybe particularly for the students, I don't think it's always inherently understandable why fixing a hole by making several other holes works. And so what do you do with those tubes? How long do you leave them in? And what happens after you pull the tube out.
Okay. So maybe you are asking about this one?
Yeah, or the last one that you discussed.
Yeah.
You know, I mean, you're fixing the hole, but you're making a hole. And then you're talking about making a T-tube as well. And so, you know, I guess when I was a student, my question would always be in my mind, like, what do you leave that tube in forever? Or if you don't leave it in forever, what happens after you take the tube out?
So technically speaking, maybe the perforation is here. You can see there's some lines over here. They don't want to put the tube directly into the ulcerated or friable tissue. They want to go through the healthy tissue to decompress the duodenum. So now your question is totally very, very justifiable, like how long you're going to keep it in there. So technically, these tubes stay anywhere from 2 weeks to 4 weeks minimum, depending on the healing to happen. So even with the T-tube, some people say 7 days, some people say 2 weeks, like 2 weeks, 7 to 2 weeks, T-tube will stay in. Even if you put this tube and a T-tube, there are still going to be drains around that, which may be taking any fluid which is leaking through this hole and outside. If there is no leak happening in the drains, surgical drains, the next thing you can do is a tube study of those things. You can put a contrast to that and see any leak happening or not. You can put a contrast to the T-tube also to make sure any leak happening or not. And if there is nothing coming out of that, so you can put a contrast to this thing. It will tell no leak happening at the tubeostomy side. It will show also no leak happening at the site of the repair done. Then leave it there for 2 to 4 weeks. Do the study again at 2 to 4 weeks, and then you can start deciding when you pull it out. That gives the answer, or?
Yes, I guess the last question, I'm sorry to interrupt your talk.
No.
So you pull that tube out 4 weeks later, and there's a tract that makes it drain to the skin, right?
Yeah. So track is there. Mostly this tube, they say using the word pelvic drain, but this is a Malacot drain. The red rubber catheter, it is made of latex. Obviously, we can't use them in a patient with a latex, but latex causes a lot of allergic reaction and make a very good track. And the track which is going to come out is going to be 20 or 30 centimeter long track, which from the duodenum all the way to the abdominal wall. And normally, there is no leak happening on those tracks. If there is something, you can just put a little bit of ostomy bag and they will just close itself. So obviously, before pulling out any drain, you have to do that tube studies. You may have to do the contrast studies to make sure no leak happening around the tube, to make sure no leak is happening during the site of perforation. That's healed properly before you do anything on that. Okay, pyloric exclusion. Pyloric exclusion means you just not letting any content of the stomach to go into the duodenum where the perforation has happened. Means less fluid or less food is going through that area, means less chances for the interluminal pressure and to increase, because also the air which you are swallowing is not going to go through that, and more chances for the healing to happen. How you can do that? There are two ways. You can do open small gastrostomy and put the stitches to oppose the posterior and anterior wall of the antral together, or you can just fire the TA stapler without cutting anything, and it can stay there for at least 4 to 6 weeks. Some surgeons are even saying it up to 3 months, but at least 4 to 6 weeks, the staple will stay in there. That will divert the stomach on the other direction. So again, if you're firing the stapler at the pre-pyloric area or the antrum, you definitely have to do a procedure for the stomach to drain it, maybe in the form of gastrojejunal. Okay. So the only complication can happen is if you're doing it, it may not be completing properly, or may can open up earlier or sooner before you want anything to happen. Like, okay, you want the healing to happen in 4 to 6 weeks, but the pyloric exclusion can open up in 4 weeks too. That can also, okay, it's not going according to plan, but most of the things which want to heal will definitely going to heal in 4 to 6 weeks. Any question on that one? No. So how are we going to use that together? This is a picture I took it last night from the American College of Surgeons website. This is a patient who presented late with the undiagnosed perforation of the duodenum. And then again, they use the tube duodenostomy. They put the tube in the perforation sutured around the tube and put Omental on top of that. They did the pyloric exclusion. This is not a cut. This is just a staple over there, the way we have done. And the drainage procedure in the form of gastrojejunectomy, plus gastrojejunectomy tube placement for the decompression of the stomach and the feeding tube. This is done like the same, the way they did the GJ tube is make sure like if this opens up earlier and you still need more time, you can still decompress the stomach to the GJ tube and feed through the jejunostomy tube. So all these things you have to be carefully calculated that if this happened, what you can do, if that happened, what you can do, and what are the best situations you can get the maximum benefit to the patient in a controlled environment. So any question on this one? Yeah.
I've always just found it super interesting that with this pyloric exclusion, it's able to just like recannularize.
Yeah.
And so I just don't understand like the phenomenon and how that happens and why it doesn't happen in like other situations. Do you know more? I guess like
It's mostly because the problem is you're not cutting the tissue and the mucosa has the power to grow again. So if you're putting the stitches, like stitches, maybe you're putting a vital stitches, they're going to get absorbed in 4 to 6 weeks and the mucosa is going to regrow. And if you're firing a staple, the staples are fired over there, they can fully putting some pressure and mucosa will open up again. So this is one way of doing that. I put this picture over there because one of my program director, Dr. Zato, bless his soul, he always found of this procedure, gastrojejunectomy with omega loop. He always want that. This is called a poor man's Roux-en-Y. Dr. Fritz used to say all the time. So this is a Roux-en-Y, but no complications of Roux-en-Y because you're never going to cut the blood supply of the tissue. No herniation, nothing else. But again, you can see the perforation is in the D2 part, is a long one. You repair that primarily. You're putting the tube duodenostomy through that. And then you are reconstructing with omega loop, you can still get the drainage through that. And you can still put a GJ tube, and GJ tube can go into the efferent limb and work as a retrograde duodenostomy. I'm saying that because I have done that, only one case with him, and he did it in the same way. He did all the things because the perforation was in the junction of D2 and D3, very comorbid patient. In the fent, like albumin is good, hemoglobin is good, but he having some lot of adrenal problems, corticosteroids and everything in the body. So he did that. Luckily, patient survived. And obviously, that's how you say you can manage those things. So, and I found this picture somewhere on the Google images too, and I put it over there because this is another way you can do. Again, pyloric exclusion is used over here. Tube duodenostomy used over there. You can put GJ and do a retrograde duodenostomy too to decompress the efferent limb too. So it works with the drainage plus decrease the pressure in the lumen of the bowels, both. Okay. One of the last thing is a jejunal serosal patch. It's not a lot of things over there. You want to ask question, go ahead. This is maybe the last topic we're going to talk about that, jejunal serosal patch. So it can be done in both the way, in a traumatic rupture of the duodenum, or it can be done in a complicated duodenal joint perforations too. So there are two ways of doing that. So if there is a perforation over there, you can primarily repair the perforation and you can use the jejunum as a patch on top of this repair. How you're going to do that patch is anti-mesenteric jejunal serosal border is sutured to the serosa of the duodenum. Only serosa to serosa, not going through the lumen. Okay. Again, this procedure can be combined with a retrograde duodenostomy. If it's too big, it can be combined with a lateral duodenostomy, depending on the condition of the patient, depending on your comfort level and hemodynamic stability. So all the three factors are there. Tissue factors are there, patient factors are there, and the comfort level of surgeon. So all the three have to be there so you can get the best out of the birth situation. And again, I have said that can be used pyloric exclusion, drainage procedure, duodenal injury, or perforation. Again, jejunal serosal patching is also called a TAL patch. So in this, you can see that maybe the perforation is so big, you can't repair the perforation. So you can stitch the edges of the perforation with the serosa of the jejunum and make it a patch, which can also work. Otherwise, you're going to compromise the lumen of the duodenum. It may cause a lot of stricturing, it may cause obstruction later on. And together with the gastrojejunectomy or the lateral duodenostomy, whatever you like to do. So these are the options which we have. There are other options too, like you can do enterectomy and then all the tube drainage combined together. So most of the procedures which are going to happen is going to be hodgepodge and combination of these procedures. And you have to use your judgment how you're going to use that. Are you comfortable with it or not? Are the patient is hemodynamic stable to undergo the resection or not? Or you can just manage with the tube drainage too, with the primary repair. Again, the end product is developing the stricture or not, is developing the obstruction or not, is developing the leakage or not. If the leakage happens, how are you going to fix that one too? In the one thing which I want to show that this tube duodenostomy, all these procedures were done for the post-operative leakage. Means they have already repaired the perforation once, it leaked again, now it's making a more challenging procedure, how are you going to fix that thing? And they have done the tube duodenostomy plus drainage procedure plus maybe the adding the T-tube or not. It makes a so much complex procedure in one patient, but that's how you're going to control that. Because the problem with the duodenum is the 3 liters of fluid is going through that area, even in NPO state, minimum from the liver, pancreas, and the stomach, and how you're going to drain that. And plus, how you're going to decrease the pressure in the lumen of the duodenum, because both the things are required for the healing to happen. So it's just a combination of all these procedures which you can use to get the best outcome in the worst situation. Any questions? Yeah, go ahead.
Could you go back to that slide with the omega loop?
Which one?
The slide with the retrograde jejunostomy and the omega loop?
This one?
Yeah.
Yeah.
So you mentioned using, again, a retrograde jejunostomy. How would you recommend feeding these patients in the midterm timing?
So you can use a gastrojejunostomy and you can put it in this way too. It will function because there's a common channel over here, right? That can work for the aspiration and the feeding too. But you can just put it over here and the patient heal properly, you can feed through that too. Or the other option is you can do the EGD, pull this tube out and flush it through that way too.
Okay. So just repositioning the tube after you have like adequate healing and decompression of the...
Yeah, the feeding can still happen because here thing is the patient is still able to eat and drink. The main thing is to decompress this area. So if you're putting a GJ tube to decompress this area, you can still decompress that. If the leak is happening in this area, you have drains for that. Even if you're eating, you can get the food so that food can go from both the directions. Ultimately, the food is going to go into this lane. But
Thank you.
if you have just a gastrojejunostomy, the food is going to go here, food is going to go this side, but there is no common channel, it's going to get stuck here. But right now, the peristalsis are going this way, they're going to throw it out here. Peristalsis is going this way, going to throw out on this way.
Thank you.
Dr. Singh, great talk.
Thank you.
I love talking about all these anatomical troubleshooting decisions. You know, surgery at minimum is still a creative art in many ways. I had a question about tying the omentum to an NG tube, because I have never done this. Do they use a dissolvable suture for that, or how do they make sure that the omentum is separated prior to removing said NG tube? And then I have one follow-up question.
Yeah, so they use the philosophy of Dr. Graham or Colin Jones using the catgut.
So they use catgut. Okay.
7 days will get absorbed. You just pull it out after that. Or sometimes they even do the endoscopy too without looking into the patient, not insufflating, just going plain endoscopy to look into everything before they're pulling out NG.
Yeah, I was thinking about that, and it's like insufflating in that area would probably be.
They will not insufflate. They will go the scope without insufflation.
And then I have one other question in regards to the vagus nerve.
Yeah.
Because none of these surgical procedures that you've mentioned have commented on how to manage the vagus nerve, whether patients were on a PPI preoperatively or not. Do you have any recommendations for when we should do a vagotomy? Should we ever do one anymore?
Yeah. So if you look into the lateral duodenostomy patients, they have done the vagotomy. And they have done the selective vagotomy, not the full vagotomy like old school, because PPI there. So selective vagotomy again, the person who know how to do that, they are only going to do. I have done one case with Dr. Fitzgibbon where he went all the way to the GE junction and little bit of superficial cut on the nerve on the esophagus GE junction, not to go through that to the selective vagotomy too. So they have done the vagotomy too in all these procedures. Where the leak is happening, perforation and bleeding, they have done the vagotomy too.
That's Singh. Excellent talk. Thanks so much. Few questions. What about Zollinger? What to keep in mind?
Yeah, Zollinger obviously is a complex thing. It will take into different pathophysiology, and location of the tumor is the one which is going to decide the procedure.
So my question is, I think those are emergent, urgent cases, and sometimes we as surgeons forget about it. So it has to be part of the thinking postoperatively. What do you recommend as the workup that it's not missed?
Well, obviously in the emergency situation, we don't even know that it's a Zollinger or not.
Don't, but we have to think about it.
Dr. Kathleen has one patient,
Right.
She did that. And obviously, and that gastrin, and well, the PPI worked very well in that patient post-operatively. He recovered well, and he was asymptomatic, and after 3 months follow-up, he was doing fine on the PPI alone. Maybe the gastrin level was not enough to cause so much problem for this patient.
I guess where I'm trying to go is giant ulcers in 2025 are extremely unusual.
Well, you did that with Dr. Punja, right?
True.
Yeah.
But what we did is we had to exclude cancer, Zollinger, gastrin several times. So I want the residents and learners to know this is an important grand rounds. The management, as you see, is variable. There's multiple options. However, it's exceedingly rare. You have to think, is this an underlying malignancy? Because most ulcers do respond to PPI. So that's the thinking that we have to also keep in mind. And when you have a giant ulcer, is this in the setting of a malignancy? So yes, Dr. Punja invited me to help on a case. We aged, I think, from that case together.
So I will just give some examples. So 5-6 years, we did one case with Dr. Punja, a giant duodenal ulcer with bleeding, hemodynamically unstable patient in the ward. With Dr. Punja, there were 2. So they already given us 6 units of blood, then they called me. So how to control the bleeding on that patient? It's still oozing from the fibrous tissue. We put a Doppler on the GDA. GDA was already occluded. Nothing going through the GDA. Still lot of blood was coming out of fibrous tissue. So whole pressure, nothing else. So I just used the epinephrine soaked gauze and put directly into the mucosa, and that helped. Bleeding stopped. But the patient is still very unstable. We did a lateral tube duodenostomy, close the mucosa. That's all, nothing. Bring it back in after 72 hours. Then we did an enterectomy, selective vagotomy, and a gastrojejunostomy. That was the hemodynamic unstable patient. And Dr. Al-Rafai was talking with Dr. Punja, had a posterior wall perforation in the body of the stomach. Obviously, as we said, rule of the cancer and Zollinger syndrome too. So in that case, he did a damage control immediately in the middle of the night. Next day, stabilized the patient, and Dr. Al-Rafai and Dr. Punja helped in doing the subtotal gastrectomy with the reconstruction. That's also turned out to be non-cancerous, but again, go to the history. Patient was using NSAID as a chewable gum 24/7, and that was causing the perforation too. I have seen more perforation in this area than in the New York because depending on the different population strata too. Third case is Dr. Kathleen did that perforation in the lesser sac of the lesser curvature of the stomach, which is 4 centimeters. Again, she did the enterectomy plus subtotal gastrectomy and reconstruction. And then again, we had a perforation, which I just showed you the picture, was at the D2, D3 area. That was not from the Zollinger. That is from the adrenal gland was secreting every kind of hormone you can see. And that's putting so much of stress, and that caused the perforation on that patient. And we used that procedure to help fix him, and he was fixable. But again, he had to go through all the workup later on.
So I think part 1 is manage the problem. Part 2 is think, why did it happen through the hormonal workup? Another question, during my training at UCSD, Dr. Musa used to do the Musa patch, where the falciform ligament is preserved, and then it can be used to patch instead of the omentum. Because some of those patients, the omentum is actually quite obliterated, and you don't have enough to bring to patch that area. So as a result, I always preserve the falciform.
So even if we are doing that, something stopped. Even if doing the falciform patch, it's going to be called as Phelan-Jones repair because you are using the falciform flap, pedicle flap.
It's called Musa's patch.
But again, the procedure. procedure is a patch is that one, but yeah, again, you're not using a Mentum, you're using the Felsi. Yeah.
Other questions for Dr. Singh from Zoom or on the floor? What's your preferred approach and why?
It all, again,
Yeah.
situation to situation.
And for the residents for ABS, what do you recommend?
If a 1 centimeter wall thickness is good, just go for the omentopexy and the primary repair.
Mentopexy,
Omentopexy.
not plugging.
Plugging is like
You want them to say an exam.
primary repair with a omentopexy.
All right.
That's
And
good because everyone, because we have
ulcer?
PPI to put them in a PPI, plus make sure you have all the antibiotics going, plus the fungal coverage. So if you have all the three things done, PPI, antibiotic, and fungal coverage, you will get the result. And make sure the NG tube stays in the pre-pyloric area for 4 to 5 days, and do the contrast study before you start feeding the patient.
Winder, I have a question. That was a very nice summary of, very straightforward summary of what to do with these problems with the ulcer. But what a question that plagued me throughout my career was the patient gets an upper GI, either the upper GI barium state or a CAT scan, and a giant duodenal diverticulum is diagnosed, and the medical people are scared to death with it. How do you manage your giant duodenal diverticulum? I know that's a little bit unrelated to what you talked about, but it's something that I've always wondered
Do you want
about.
to repeat the question so people?
So the question is asking about the giant duodenal diverticulum, mostly which is happening in the second and third part of the duodenum. And mostly they are retroperitoneal in the area. So if this is a small perforation with the leak, those can be managed conservatively because in the retroperitoneum, NPO, IV fluid, parenteral nutrition plus octreotide can be done to manage those ones. And Dr. Emily knows that because she called me on the trauma service for the management of giant duodenal perforation in the D3 area. There was a lot of fluid and abscess, and they drained that. A lot of bile was coming out of that. So we follow the three things: octreotide, NPO, NG tube, and parenteral nutrition. Within the 3 days, the output comes from 600 to 100 and slowly goes away. But again, what happened is she developed the stricture at the D3 area because the perforation was so big and a scar development. And after the final procedure, she need a duodenal jejunalostomy as a final procedure to make sure the continuity of the GA tract is maintained. So again, it's a complex thing. The slide which we have shown where Dr. Alvaro did the procedure, it was due to the duodenal diverticulum in the D2, D3 area where he has used all these things. As long as it is a retroperitoneum, you can not causing much of the complication, you can manage conservatively. It is causing too much of infection, you can drain that. Again, with the concept in the mind, it can develop a stricture later on, may need a further diverting procedure, maybe gastrojejunalostomy or duodenal jejunalostomy later on in life.
Dr. Singh, thank you so much. We appreciate you covering a complex topic in a very thorough way.